Welcome to all the members. We will begin in just a couple of minutes. Few more members are joining in the queue. Dr. Reetu, shall we begin?
Sure.
All right. Thank you to everyone who is joined to our yet another interesting session of knowledge sharing. On behalf of Simplify MVT Academy, your host and moderator for this scientific session, being the business head of Simplify MVT Academy, it's very critical for us to spread the knowledge and empower everybody in the industry, especially the non-clinical members who are professionals who make the best bridge between a patient who is actually looking for care and the caregiver who is actually a clinician. So between a caregiver and a care seeker, we become the best bridge. So being a non-clinician, I think we play an important role. So it is a huge commitment on our side to conduct an ongoing sessions on knowledge on important topics, which actually empower us and help us deliver better information to our patient who come to us seeking medical care. And especially when they're traveling from one country to another, seeking international patient services. And the people who must have missed our last session, not worry, because we are going to cover an advanced segment today. And I'm sure there'll be some amount of overlap. And all the members who have joined us today, I would request all of you not to miss any sessions and keep in touch through our timelines and our information for future knowledge session information. And let's begin the session for today, which is on bone marrow transplant. And our speaker for today, who's going to guide us through this very important department or a specialty, which actually can make lots of confusion, not just in the minds of the patient who undergo, but also to the caregivers and the professionals who are involved in this. So to clear all the misconceptions and to give us a direct information, we have with us none other than Dr. Reetu Jain. She's a director of bone marrow and stem transplant, stem cell transplant, and also for academics. So this is the best thing for us because being the head of academics, she is the best orator that we could ask for and gives us an information that can be imbibed by us in a very basic manner. She's at Jaslok Hospital and Research Center. She has experience of more than 22 years. She has received her training at Tata Memorial Hospital, Mumbai. And also it's a very proud element for us to mention that, in fact, she gets cases referred by Tata Memorial Hospital for her to take care of them. This is the vast credibility that she has established. She treats hematolymphoid malignancies and solid tumors. Her special interest is in bone marrow and stem cell transplant. She's been trained in treating solid malignancies like breast cancer, ovarian, lung, GI cancers, and hematolymphoid malignancies. Acute leukemia, myeloma, lymphoma, chronic leukemia. We discussed all these elements in the last session, if you all recollect who have joined us from last session. Dr. Jain has performed more than 400 stem cell or bone marrow transplant, allogenic transplantation, which is sibling matched, matched unrelated, haplo-matched transplantation, and autologous transplantation. She is managing all hematological malignancies and solid tumors. She's on the editorial board of Indian Journal of Medical and Pediatric Oncology, and she's also the registry committee member of Indian Society of Bone Marrow Transplant and also conducts cancer awareness lectures regularly. So with her advanced knowledge and ongoing updates that she herself keeps getting for herself, I'm sure we have a very important session in the next 1 hour that we could brace upon and hold on to information. And I request all the members, as you listen to the presentation that Dr. Reetu will present now in the first 25 minutes, keep your notebooks ready and note down all the questions that you would like to ask. And once we come to the Q&A session, the question and answer session, you could switch on your camera so that we could allow you to ask your question. Or if you're not comfortable to switch on your cameras, you could type in your question in the chat box and we will take those questions, which will be answered by Dr. Reetu. So moving ahead to this advanced session on bone marrow transplant, over to Dr. Reetu Jain. The screen is all yours, Dr. Reetu.
Thank you. Am I audible?
Yes, it's clear.
Thank you, Vidyaji, for that very warm and kind introduction. And good afternoon to all of us who have gathered on a Saturday afternoon to listen to me on the second part of our ongoing series of simplifying or advanced knowledge in bone marrow transplant. So today will be a little technical terms I will be using. So if anybody has a question, maybe we can take it in the end, as Vidyaji said, or they can type it, and I'll try to make it as non-technical as will be possible for me. But pardon me if I have become too technical, so we can address it at the end at the Q&A session. So we'll begin. So I'll start sharing my screen. Yeah. So, okay.
It's perfect.
Yes. So today I will discuss on the principles and practice of what is bone marrow transplant. Last session we had touched upon the basics, like what is a transplant and what. Today we'll discuss how do we do it, what are the procedures or the steps involved in that, and the long-term results, side effects. So then we'll start now. What are stem cells? Like by definition, they are the parent cell or the undifferentiated cells, and these cells have the ability to divide and to become any cells, like our WBC cells, our hemoglobin, our platelets. So these cells are called the stem cells, and they can differentiate into any cells in the body. So that is the definition of the stem cells. So this, if you can see, this is the stem cell, which is called the totipotent stem cells. And from there, then all these cells, the RBCs, the WBC, the platelet, and the platelet, these are WBC cells, the neutrophils. So these are all the cells which can be formed from this parent cell or the stem cells. So I was lucky and fortunate to have been trained with the first transplant team of India. This is Dr. Advani, as we all know, Dr. Saikia. They started the first transplant unit in Tata Memorial Hospital way back in 1971 or 73, if I'm 73, I think. And this was Dr. Undevia. He's no more with us, but he was the immunologist at the most reputed KM hospital. And together, these three gentlemen, they laid the foundation of stem cell transplants in India. And I was fortunate to have been trained under these two giants in the field. So, what are the different types of transplants we do? Are the allogenic transplant and the autologous. So, what are the allogenic? Allogenic transplant is the transplant where a donor is involved. Now, this donor can be a sibling who's full matched and is related, full or an unrelated donor which is full matched, or even we get stem cells from the umbilical cord after the delivery of a baby. From the placenta we collect stem cells called the umbilical cord, and these are the best cells or stem cells which we can get. Or there is a transplant from an identical twin which we call a syngeneic transplantation. So in the allogenic we have to remember that there is a donor involved, and the donor can be a related sibling, unrelated, and now we are doing a haplo match or a half match transplant where we can one of our parent would always be will be half match, because as we discussed in the previous session, half of our HLA genes we get from our father and half from the mother. So there, even a mother or the father or the sister or the offspring, the son or daughter can also be a donor. Then, as I discussed, there is a donor involved, and these are the HLA identical sibling, matched unrelated donor, and a haploidentical donor. And in the autologous, what we do here, we collect the patient's own stem cells and give it to the patient. So that is autologous, means auto means self. So what are the advantages of doing from the autologous? That there is no rejection or not much complications associated with transplants, and also it can be done in an older group of patients. Whereas the disadvantages in certain cancers, we cannot do autologous transplants like ALL, AML. There we will have to do only allogenic. So coming to the steps involved, especially what are the steps involved when we are doing a transplants? Sorry. So first, if we are doing an allogenic transplant, that is from a donor, then we will do the HLA matching, and then we will give the patient high dose of chemotherapy, the recipient. Meanwhile, we will do the collection of stem cells from the donor, process it, and cryopreserve it and give it back to the patient. So these are the various steps involved in an allogenic transplant procedure. So now you may ask that which all patient, doctor, you decide like which patient will need an autologous, which patient will need an allogenic. So depending on the type of the disease, the stage of the disease. Suppose in there are blood cancers like myeloma, non-Hodgkin's lymphoma, Hodgkin's lymphoma. There we will do a autologous transplant, not an allogenic. And there are certain conditions like bone marrow failure syndromes, aplastic anemia, or we have AML, ALL, leukemias. Then in that we will do a allogenic stem cell transplant. So if we are doing allogenic transplant, then we have to see the availability of the stem cells, then the age of the patient, how is the general health. In our medical terminology, we call it as a performance status. That means patient is fit for the procedure or not, and of course the same, the clinical condition and the disease status. If there is an active disease, we will try to defer the transplant procedure. We will try to get the patient in remission and then think or start counseling them for the BMT procedure. So these are the various factors we take into consideration before we decide upon the type of transplant and when we have to do it. So as I discussed earlier, like in malignant conditions like leukemia, AML, ALL, there is a condition called chronic myeloid leukemia, juvenile chronic myeloid leukemia, myelodysplastic syndrome. So they are very, very aggressive form of blood cancers. So that in the cancer, and in the non-cancerous condition like there is a condition called aplastic anemia, where there is a failure of the bone marrow. So then in that, we will have to definitely do a transplant and replace the failed marrow by an active healthy bone marrow. Then we have thalassemia, we have sickle cell diseases. These are an immunodeficiency diseases. These are generally metabolic disorders we see in children or pediatric patients. These children are born with this kind of problems, and in those patients and in these children, then the allogenic transplants are the is the solution for them. Then autologous transplant, where we are using our own stem cells or the bone marrow. We do it in non-Hodgkin's lymphoma, Hodgkin's lymphoma, multiple myeloma, neuroblastoma, especially in children, and germ cell tumors. So these are the various indications where we use our own stem cells for the transplant. So from where do we get the bone marrow or the stem cells? Earlier, we used to take it from the bone, directly from the bone. Now, with the advancement of technology, we let all these stem cells come in the peripheral blood or the blood, and then from there we will collect. How we collect, in my subsequent slides, I will discuss that. And the third is the from the umbilical cord blood. As soon as the lady is delivering, when as soon as the placenta is out, that time we will collect the cord blood. So these are the different sources, either the bone marrow from the blood or the umbilical cord, we collect the stem cells. Then if suppose if we have to do a allogenic, like if we need a donor, so what we do, first we will do HLA typing. As we discussed last time, that we have a unique haplotype from each parent, like, and then we will do a simple blood test or a test from saliva called HLA typing, HLA test. And depending on the full match or half match, then we will proceed for the transplant. Then how do we collect the stem cells and the procedure? I will enumerate now. So this is from the bone, like directly from the bone we do in the bone marrow. So this involves the patients to be under anesthesia in the operation theater, and from the tailbone, like I will show you next, from the tailbone, we will be collecting the stem cells. Like we put the needle like this in the tailbone. The patient is made to lie down on his stomach, and this is the way. These are the stem cells. These are like blood only. So this is the way we collect. So one doctor will collect, somebody is collecting the stem cells in the blood bag and the others assisting. So this involves the entire procedure to be done in the operation theater under anesthesia. So this was one of our child of thalassemia. This is the child, and this was his brother. And the patient is now almost, I think, 8 or 10 years post-transplant. This is another child of thalassemia. And then that we discuss about from how we collected from the bone marrow. Now the second source I discussed, that we collected from the blood. So how do we collect it from the blood? So what we do now daily, we will give patients 4 days of injections on the stomach, like how we give insulin. And daily we will monitor the blood counts. So the WBC in the blood will come to normal range is 3,000 to 4,000. But then we will increase the blood counts to 10, 20,000, 40,000, 60,000, 80,000. So for 4 days, we will be giving them the WBC injections, and then 5th day, we will do the collection. So this is done in the blood bank. It is usually an outpatient. We'll admit the patient only for a day for the stem cell collection. And these are the newer machines which we have, the amicus and the spectra with which we collect the stem cells. And we put a small catheter for the patient, and the patient is lying down on a couch, and this is, we can see the blood is circulated, and we collect the stem cells. And this, one of the other patient, autologous patient, we had from the neckline, this is neckline, and this is the way the blood gets circulated, and then we collect the stem cells. So once we collect the stem cell, what do we do? Suppose if the patient is an allogenic transplant, immediately we will transfuse like blood. But if the patient is an autologous, where we will have to first give them high dose of chemotherapy, these are the stem cells, and then we will put one cryopreservative called DMSO, And then we mix the stem cells with the cryopreservative, and then we store them at minus 70 degrees. So this is the entire procedure of collection, storage of the stem cells. Then we come to the third collection of the umbilical cord blood. So how do we collect? See, if the lady is getting delivered and this is the umbilical cord. So immediately after the delivery is done, we have to just put in a needle and start aspirating the blood from the umbilical cord. The only limitation of this is that, the donor, the amount of cells which we get is very small. So generally umbilical cord blood transplants are done in pediatric patient, because as you know that the cells are less in numbers. So this is the way the umbilical cord stem cells is collected, and the preservation, or how do we preserve, the procedure remains the same. And then the infusion is done like how we do a standard blood transfusion. So after collection, how do we, so we have seen how we process, how we cryopreserve or preserve, and now how we reprocess the cells and give it back to the patient. So now once we have put the cells in the deep freezer, they become like ice. So in the we call it a water bath. So at 36 or the room temperature, we will thaw these cells like how we thaw ice, and then how we transfuse like blood transfusion, we will transfuse the patient back. So this is the way we give these stem cells back. So this is the reinfusion. So there is no surgery involved, nothing, just how we give the cells back like a blood transfusion, we will be transfusing it back to the patient. Then what happens? Then we have already transfused to the patient. So it is a multi-step procedure which is involved. So then what happens? Till 7 days, then we admit the patient in the BMT room, give them 7 days of high dose of chemotherapy. And then on the day 0, that we call it the day of transplant, we will infuse them with the stem cells. Then gradually, because of the high dose of chemotherapy, the patient's WBC platelets will come to a 0. And during this period, you can see in my slide that during this 10 to 15 days of period, the bone marrow cells come to almost 0. We actually kill all the cells in the bargain of killing the abnormal or the cancer cells. So this is the most tricky period where the patients are prone for infection, because the defense mechanism of the body is not there. WBC cells or the white cells, which are our fighter cells of the body, they are very low. So the patient is more prone for infection than the side effects of the chemotherapy which we have given. So we have to monitor for all those complications during this period. Then what happens? Whatever cells we have transfused, so they are like seed and the bone marrow is like a soil. Then gradually these cells will go in the bone marrow. They will start to function. As I discussed, the stem cells have the ability to form new cells, no? And then they gradually will start forming the WBC platelet. And once the WBC platelets are reaching 4,000, then that is the stage where we'll generally discharge the patient. So average, this whole procedure takes 1 week for the collection, 1 week for the high dose of chemotherapy, and 2 to 3 weeks for the recovery. So on an average, the patient is hospitalized for 2 to 3 weeks in the case of autologous transplant, and if there is an allogenic, 3 to 4 weeks. So this was a child we did in 2006, and this was a brother who was the donor, full match. And this was the child who came in 2008, and then she was all right. So we have not, last follow-up was in 2009. So now she must be a teenager now. And this was the same child again, he had thalassemia. And so that was in brief about the whole procedure of transplant, how we do, and what are the steps involved. So I thank you all for a very, very patient listening. And if any question answers are there, we'll be happy to take them.
Thank you, Dr. Ritu. That was quite interesting because the slides were very easy to comprehend, and you had used really very informative pictures and more like, the cartoon characters kind of images made us more easy, relatable, and it was seamless in terms of the whole process. That was very interesting. Before the audience questions comes in, I would like to ask some of my questions that I would like to take forward from here. We got really a very clear picture about how the whole process takes place in terms of right starting from investigation up to finding a donor, and then the transplantation in terms of cryopreserving, thawing, and then re-transfusion and everything. And in this whole process, when the patient is with us, do we have any particular resources that we can provide to a patient, like any material that they need to constantly go through in terms of educating themselves? Or is there a support group that they have to be involved with? Any particular resources that you follow that would help the patient in terms of being engaged through this entire transplant journey?
Okay, so we have information booklets, Vidyaji, which we give it to the patient and the attendant. And what happens, like generally the patient, we start counseling them. Like the treating doctor would involve us early on when he or she feels that the primary doctor who's treating them, and he or she feels that this patient may ultimately maybe requiring a transplant at a later date. So they also start their primary counseling that, once your disease is in remission, you may have to consider for a transplant. And then we will do the first counseling of the family donors, try to make them understand about the entire procedure. And if they are from outstation or out of the country also, international patients, then we have a coordinator also. So we counsel them. Then there is a counseling of the nurses being done, like how many days they need to stay, what to expect. So though we handhold with them during the entire process, the stay in the hospital, in and around, what complications to expect, what will be the cost involved. Then even a few patients we have lost because their situation was very difficult, or they came with a very bad infection, or subsequently they developed. So all this we first counsel the patient in detail. And once the patient and the family and their treating doctor are ready and willing, then we take for the transplant, because autologous is not so much of an issue, but allogenic, yes, because there are long-term complication associated. Patient needs to be in and around Mumbai, or suppose if we have international patient and in their country or in their city or in their town, if they have a transplant doctor or a doctor who can follow up and be in touch, so that is then we will transition the patient back home.
Perfect. I think that will give them a really clear hand holding through the whole process, and
Yes.
also that last mile connectivity with their treating doctor also will develop their confidence level to be higher. And
Yes.
it was interesting that in your slides, you took us through the origins of the doctors who initiated the bone marrow transplant in India. So I'm sure it dates back to 50 years ago. So India has 50 years of history of probably, developing the bone marrow transplant treatment methodology itself. So, as since we are all, everybody, the members that who are listening today, handle essentially treatment abroad. And one of the important decision making everybody comes across is which country to choose for. And patients, as you know, they shop around, they look for different countries, take different opinions. And I want to like list a few salient features or best decision making, because this is a very critical treatment. It's not something like a cosmetic procedure or not an elective procedure. It's a life saving procedure. So it's important for them to make a right decision. They can't shop around and go to some place. So I want you to help us highlight why choose India and why India is the best place in terms of, not demeaning other countries. I'm sure this development happened everywhere else, but tell us some of our important strengths that we have in India that patients should opt for to come to India.
Mm, That's a easy as well as a difficult question. If you, I have to think, I have to actually see from a patient's perspective, why choose India, as you rightly said, because there are many centers. Uh, what first thing comes to our mind is a personalized care.
Mm.
Doctors are always available in India, you know. uh,
Absolutely.
that's one of our USP, I would say, because many patients who come from abroad, and we have now medical tourism, gaining popularity in India also. So they feel that doctors are available, even the senior doctors are available on the phone, or and this appointment system is not so much delineated. Like that informality of access to the doctor, I would say, is one of the important things in India. It all over, not only, I'm not talking about Mumbai or our center, but yes, this is the general feedback. So availability of doctors. Second, suppose some patient is from, I'm sure other countries also must be having translators. Then third, coming to the very important aspect is the cost. You know,
Absolutely.
cost also, compared to the other countries, I actually have no direct cost to cost comparison, but definitely in terms of cost or expenses involved, it might be coming out to be more economical than the rest of the countries. That is the third thing I can think of. Fourth is availability of all specialists. Suppose, especially doing an allogenic is a transplant is an art, and a haplo transplant, sibling match transplant, because procedure wise, if you can see, there is no operation, there is nothing, it's just by medical, and a good follow up is required. But sometimes some patient gets some kidney problems, so we have a good interspeciality, interdisciplinary help with us. Like we have ID specialist, we have a kidney specialist, we have a lung specialist, we have good blood bank support. So majority of the hospitals in India who are doing transplants, all of them have managed to develop that multi-level care for the patients. So these are the few features which comes to my mind, that India might definitely having an added advantages over the other nations.
Absolutely. I completely agree with you. Because one of the members were talking to me yesterday, and they said in their country, they never get access to reach out to a senior consultant. And it's only, the nursing
Yeah.
department who would actually give them the follow-ups. So this is something extremely critical. And cost-wise as well, I think it's far more competitive in terms of costing. Very critical elements in terms of patient decision making, and very important building blocks, very beautifully summarized. Thank you for that. If we go to the technical aspects of the whole patient care that you mentioned, one of the pictures that we saw is, in the you're extracting the stem cell from the donor, and after the donor gives the sample, is there any side effects for the patient, for the donor, or what measures, or what in terms of care that they need to take care of themselves to ensure that they do not face any low back problem or anything else that that they could come across in terms of side effects? Is there anything that they have to be very careful in terms of donor?
Yeah, that's a very, very important question. So first, everybody has to understand that we will not put a second healthy donor's life at risk to save another patient, So that is for sure. And that's a very, very important question, because even in India, we have a few donors, and India, we have, a lot of family members also involved in decision making. So many a time, especially with married donors, like sisters, and their family members have refused, though she was a full match. They thought that something will go wrong to his wife, or so they refused. So for the donor, it is absolutely safe. Our youngest donor has been 3 years old, and we prefer to take younger donors for one reason, because of the quality of stem cells and healthy stem cells. As we age, we know that all, even our cells quality also becomes a little not so it's not so great as compared to from a young donor. And our oldest donor has been, I think, 56 or 60. We try to avoid, but if we have no other donor, then we would take it from a older donor also. So that is the spectrum of our donors, right from 2 to 3 years old till 50, 60. As regarding your second part of the question of the safety, it is completely safe. There is no issues. Only when we suppose give them the injections to mobilize the stem cells, at times they may get temporarily back pain. That is the only pain they might encounter. And in a few patients, where veins are an issue, then we put that line in the neck here, like, for the venous access. So that time little pain or discomfort is there, but it is an absolutely safe procedure for the donor.
All right. Yeah, I think that clears the misconceptions, because the moment people are familiar with organ transplant, where donations are given in terms of organ itself, but here it's completely different aspect altogether. It's the stem cell which will be donated, and it's regenerated again into our body, isn't it?
Yes,
So
yeah.
it's
Yes, I
nothing
wanted
that
to.
I'm losing. If I donate, I'm not losing anything. Like if I give one kidney, I've lost that kidney. But here, if I donate my stem cell to my sibling or anybody it matches, I'm not losing anything. It regenerates back again to my body, isn't it?
Absolutely, absolutely. It's like giving blood platelet transfusion. In fact, if you give blood, you can't, if you have donated blood for the next 3 months, you can't. But platelet stem cells, they will regenerate in the matter of few hours. So you are not essentially losing anything.
Absolutely. Yeah. Thank you. I think that is a great, the removal of the misconception that most people would have because of the terminology itself.
Yes, yes.
That's clear right now. And I would like to move to the next aspect of after the collection is done by the donor, and then you cryo preserve it, and you're taking the patient through the chemotherapy session to bring the WBCs down. And for some reason, in case if the patient is not capable to take the transfusion, how long can the cryopreservation happen? How long can you keep that? Is there any time period to preserve that stem cell that is taken, or is there any time limit that you have to donate within the time frame?
Okay. Vidyaji, we will take the patient for transplant only if the patient is physically, mentally fit and accepting the procedure, right? But
Okay.
sometimes, in conditions like multiple myeloma, where or lymphoma, where if we are continuously giving them chemotherapy to put the disease in remission, sometimes the stem cell quality gets damaged because of continuous exposure to the chemotherapy. So in those situations, what we do, we will collect the stem cell as soon as they achieve a remission, and then, because we know that this quality of stem cells is good, we will cryopreserve it and then give them some more chemotherapy to achieve that remission. That is one thing. So in some cases, we do preserve it. The question, the duration, we can preserve it for 20, 25 years also. So there is no problem. Yeah.
That's quite
And
a
in
long.
certain situations where we think that the patient may need a second transplant, so we collect additional stem cells and keep them stored. This is a standard practice all over the world, that especially in myeloma, if there's a young myeloma, and we know that the first transplant is going to be of help for 5 to 6 years, and subsequently the patient may need a second transplant, which we call a tandem transplant. We collect it at the one go and preserve it for 20, 21 years.
Okay, so you have a bank which would collect the stem cells and preserve it for the patients.
Yeah, we preserve the cells and we send it to the bank.
All right. Okay. Okay. That's very informative in terms of that whole process itself. And then the upward curve. We saw this curve that you had shown, that once the transfusion is done, then the upward curve is there when that was a rejuvenated patient, which was like really showing happy face with the hands up. And how many days after the transfusion does patient go to that level of enhance of complete rejuvenated phase? How many days does that take?
2 to 3 weeks.
2 to 3 weeks. All right. Do they need to stay in the hospital for 2 to 3 weeks?
They are in complete isolation
All
because
right.
after the chemotherapy
Immunity is low. Right, right,
and the patient's WBC platelet, all the cells come to zero. So
right.
that is the period where they need complete isolation, strict monitoring for infection and the side effects.
Right. And during this phase of the transfusion and before the collection, they go through the chemotherapy, and then they have this very low WBCs and then wait for it to increase after
Yeah.
the transfusion in isolation. How is the nutrition and the diet? Is there any oral diet that is allowed, or they are on fluids, or only IV fluids? What kind of nutrition are they given, or what is it allowed for them in terms of diet?
Diet, whatever the patient is able to eat, so there is no special diet restrictions, but we provide it from the hospital in the sense we have to maintain the hygiene so that they can have vegetarian, non-vegetarian food of their choice. And we will pass to the special ultra, like even if it prepared from the kitchen of the hospital, we will sterilize the food again before giving it to the patient. That is one extra precaution is taken. And if they don't get much ulcers, or because some chemotherapy drugs which we give, they cause a lot of ulcers in the mouth, so that is the time they may not be able to eat spicy food or solid food. So then we will advise them to take a liquid diet or a soft diet. And if sometime patients are unable to eat at all, or they get severe form of oral mucositis, then we give them parenteral nutrition also. But on an average, most of the patients are able to eat. But
Right.
in
Just
children, I
talk
think pediatric patient are pediatric transplanters. They have to put even the feeding tube for the children. But in adults, we don't see much of that of an issue. So patient
right.
is free to eat the food of his or choice.
Solid intake is available. It's
Yes,
possible.
yes. Yeah, yeah. And
Perfect.
patient is all conscious, sitting in the room,
Mhm.
watching television. We allow an attendant also to be with the patient all the
Right.
time. So, and many of them who are working professionals, they bring their laptop. They are working from the transplant unit also. The whole idea is to keep them engaged and occupied.
Correct, correct, correct. Yeah. And also, I think psychologically, it gives them more hope and more confidence to brace with it and go ahead and
Yes,
ensure that this is a very comfortable procedure to go through,
yes,
and
yes.
they would really come back with a very good quality of life. This
The only
leads
thing,
to,
Vidyaji, sometimes the isolation, some patients are very much scared because they have read on the internet or some, in the family or friends. So that isolation period is challenging. So
Mm,
we allow one of the family close attendant to be with them all throughout. Then we have even in-house oncology counselors are there, who visit them on a daily basis. Nurses are there. So some or the other patient is not left all alone, but the fear is definitely there because they are in a different
correct.
environment, isolated, and mobility is restricted. So but I think by the first week everybody get adjusted in that isolation period and the room.
Right. I think COVID prepared all of us in terms of isolation, but
Yes.
nonetheless, it's not easier said than done. Somebody who's going through that. And I think in the digital era, it makes it all the more easier because you could connect with video calls with families and stuff like that. But leading this to my next question is at Jaslok in particular, what kind of psychological counseling availability do we have both for the patient and the families? Is there any structured counselors that they visit them or giving them
Yes, yes.
part of the
We have.
protocol that you follow?
Yes. So a
Right.
dietitian visits them on a daily basis, and a counselor at baseline, like that's they are a part of our team. Even if the
Mm,
patient actually doesn't have, but we try to make them familiar. They build a rapport with them in case subsequently later some patients, especially in the first week, see we experience that most of them get a little anxious, and they have that fear. So we have, and they are trained psycho-oncology counselors from Tata. And we have in-house psychiatrists also, and our nursing staff are also quite senior. Few of them have been around for past 15, 16 years. So that kind of support is like an ongoing support. The patient is not alone. And if because there is lot of mental block, if we tell the patient that some counselor will be visiting you, then they will say, no, no, doc, I don't want, I'm fine. So but it takes a while, but everybody adapts subsequently.
Correct. I think that itself sometimes becomes a taboo to even see a
Yes.
counselor. And maybe indirectly, as you said, even the nursing staff, having seen so many number of cases, would be able to deal with them in a more compassionate way. And I think that would help them indirectly.
Mm.
Uh, we did speak about the side effects probably that would a donor would go through, but I would like to ask you: is there any side effects that a patient who takes the stem cell transplantation, any possible side effects that they have to be careful about, and what precautions that they need to be aware of or be prepared in terms of any complications or side effects?
I actually thought today I just discuss about the procedure. I had a few slides on the complications and all, but I thought that will be, I mean, a little information overload. So I, purposely didn't show the slides. But yes, so for the donor safety, we have discussed, but the patient do get a lot of side effects. See, the protocol, Vidyaji, is more or less the same all over the world. If you go, the chemotherapy protocol, what chemotherapy has to be given, more or less it's standardized because all over the world we follow the Western protocols from the US, the UK. How the body takes it, how well prepared you are nutritionally, a physical fitness of the patient, all these factors also matter. So if you're doing an autologous, essentially the side effects of the high dose of chemotherapy, nausea, vomiting, hair loss, infection, diarrhea, these are the general side effects of an autologous. In allogenic, where there is a donor involved, though if suppose they are full match donor or the cells are completely matched, but these cells are foreign for our body. So sometimes they react, even though they are a full match, they will react in the terms of we call a GVHT, the graft versus host reaction. So they might be skin peeling, might be there. Then they may get jaundice, they may get diarrhea. So we are always on the lookout for the side effects of the chemotherapy and the side effects of the stem cells given to the patient. So most of these complications are manageable, and most of the centers manage it not to go to a very so much extent or the severe extent that patient sometimes we have lost patient due to these complications. So these are the acute side effects on the complications. And sometimes in the chronic side effects, they will have a dryness of the eyes, dryness of the mouth, where we call again a skin GVHT. Sometimes the liver also can get damaged. So these are the side effect, long-term side effects, and especially in male patients, sometimes the high dose chemotherapy can affect the sperms also. So we ask them to do sperm banking, and especially in children, if a child is being like they are doing so, there will be stunted growth as they grow, because see, they are curative procedures. Patients who have managed to come out of that complicated period, or they have sailed through that period where life is at risk, then long term side effects may they will have a little stunted growth, or even thyroid problems they may get. So these are the long term side effects of transplants.
Mm. As you mentioned about sperm preservation, is what about for women? Can she get pregnant after that?
Yeah.
Would she be able to conceive a baby?
Yeah. So again, it depends, especially as we discussed in the first session, the ovaries or the ovum are more resistant to the side effect of the chemo, but the sperms get damaged very easily. So now in India, we have a procedure called oocyte or ovum preservation, which we can do it before the transplant. But typically, when we see patients, they had already received chemotherapy in other centers, and then they come to us for transplant. So in women, it is still reversible after transplants. We have patients who, the young patients who got married, have conceived and have had children. and a few ladies couldn't conceive. So that is one issue. But yes, now ovum preservation facilities are definitely there,
Right.
available.
Right. And what about the general other lifestyle? Would they get into complete normal lifestyle, get into, if they are younger, get into college or studies, or somebody who is a working person can go back to work, have physical fitness? What about the lifestyle? Is it generally as good as any other normal human being, or do they expect it to be anything different?
No, if it is an autologous transplant, Vidyaji, the first after they get discharged, average the autologous patient will get discharged in the 2 3 weeks maximum. In a month's time they will get discharged. They get discharged, and then depending on their condition at the time of discharge, we ask them to isolate or not go to work for a month. And the third month onwards, they are all back to their routine activities. And if suppose in myeloma patient we need to put them on maintenance therapies, then they will see the doctor every 3 months. But if it is a lymphoma patient, then we may not have that much of follow-up. But yes, definitely we follow up the autologous patient for the first 5 years. And then in the next 3 4 months, they get back to normal life.
Okay.
Regarding when the patient undergoes an allogenic transplant, they need a longer follow-up, and
How
they will
long?
be on
How long do
immunosuppressive.
they need to follow up for
Yeah,
allergy?
yeah, if they have not much complication, they will be on immunosuppressive drugs for 6 months to 8 months, sometimes a year post-transplant in uncomplicated patients. Then we gradually stop their immunosuppressants, and they 3 4 months, if they're all good, then they are back to their normal working life and are the normal life. But if they did have a complication of GVHD, this is one of the major side effects of a donor transplant. Then they need a longer follow-up. They will be on immunosuppressants for a longer period of time. But if the patient's general health is good, even on those drugs, they can go back work or live a normal life. But
Right.
yes, in the supervision.
And what is the life expectancy after this transplantation? Does it mean that it's curable for lifetime?
That's a very important question. Like even after transplant, is as I discussed again, in what indication or what kind of disease you are doing the transplant. Okay, suppose there is a very high risk of patients. So even after transplant, they will have a 15 to 20% chance of recurrence even after the procedure. So those patients who don't relapse in the first 2 to 5 years, we consider them as cured. And the high risk patients, yes, we have had patients who after 2 years, 3 years, they have come back with disease. But the patients who have gone through this 2 to 5 years observation period without a recurrence or relapse, they are cured for life.
Right. I've actually taken the questions from the members who have sent on chat. And one of the question is, you did mention, you showed us the slides as well of younger children, and also you had patients who are about 56 or that kind of an age group. So you have seen the wide range. But is there any best age for a bone marrow transplant, where the body is most susceptible or more compatible to actually take the transplant?
We prefer definitely, like again, it depends on the disease. Like if we have a 60 years old patient who has acute leukemia, AML, ALM, we would discuss with the patient about the possible side effects, including the risk to life. Whereas if the same patient has myeloma, where we are going to offer him or her autologous transplant, where the mortalities or the risk to life is very less, then 60 years is not a problem for us if you are doing an autologous. But if we are considering an allogenic, then yes, there is an upper limit where most of the center would prefer a younger patient, 20, 30, 40, 50, 50, 55 is also a good age. But in a donor transplant, younger the patient, better is the outcome.
Right. Yeah. So because they have a longer lifespan that they could really look forward to. Yeah. And in terms of leukemia, will it come back after bone marrow transplant? Is there a
That's what I said. If let's suppose if a patient has a high risk leukemia, let's say AML, it is the worst form of any amongst all the blood cancer. We have a condition called acute myeloid leukemia. So that is one of the worst. And in that also, if we categorize them into high risk, low risk, or intermediate risk for relapse, like staging wise. So if the patient falls in the high risk category, even after transplant, this patient will have 10 to 15% chance of recurrence or relapse.
Right. And another question coming through is, does a bone marrow transplant change our DNA?
It will change the cellular level. Like in a autologous, there is no change in the DNA because they are our own cells. So there is no change in the DNA. But in the allogenic, where we are using another person's cells, like stem cells. So there is a DNA doesn't change. The cells will change. The bone marrow cells change.
So there will be changes in the cell formation.
Blood group changes.
Okay. That's
So like
interesting.
if there is a blood group mismatch, the donor is O and the recipient is A. So then they will change. And that is the success of the transplant, that even the blood group has changed. That means the body has accepted all the cells of the donor.
So the recipient's blood group becomes O if the donor is O.
Yes.
Right. Oh, that's an interesting factor.
Yeah.
Okay. Another question coming through is it compulsory to get chemotherapy before BMT, or can it be done without chemotherapy
So
before you go ahead with
I
the
think
BMT
that is
process?
the main crux of the whole talk, that we have to make the bone marrow empty to receive the new cells.
Become
Right?
zero.
Yeah.
Ah.
We have to vacate the bone marrow
Hmm.
to let the new cells come home in and grow. It's like that.
That is the scientific angle behind it. So it's like cleaning the whole place and reimplanting the new seeds
Yes.
so that a fresh the growth happens.
Yes.
So
Exactly.
the past thing has to be removed. Perfect. All right. That's an important aspect. Good. I think that got reinforced in our brains right now. Thank you. And okay, another question coming through is, I know we talked about preserving the sperms because it's more there is chemotherapy can cause damages. Does it mean that it causes infertility?
Yes, especially in males, because the high dose chemotherapy, as I discussed, in the males, the sperms are very sensitive to the side effects of the chemotherapy. So long term chances of infertility, sterility are there. So, but
But
majority of
this could hold good for any kind of chemotherapy, right? Not just here
no,
in terms of BMT.
no. So when patient comes to us, they have already received a lot of chemotherapy to put their disease in remission, right?
Hmm.
So the treating doctor, the oncologist now make sure that, suppose even if we are giving routine chemotherapy where we know that this chemotherapy will be particularly damaging to the sperms, they do sperm preservation before we start the chemotherapy.
Mm-hmm. So, in case of younger men or women, and if they have been able to preserve, what precautions do they need to take in terms of before planning a family? Do they need to, in terms of enhancing their overall physical health and also the health of getting their if they have preserved, it's fine. If not, how can they become more fit in terms of conceiving or planning for a family?
No, see, your first question, that is there any precaution? No. We generally wait for 2 to 3 years or 5 years, because during this 2 to 5 years period is the chance of recurrence or relapse even after transplant. So we will advise them to pass that safe zone of recurrence, and then patient can start their families. That is one aspect, the
Need to give that
duration.
gap of time before planning,
Yes.
right?
And then the second part aspect of your question is, do they need special precaution? So precaution is no. Sometimes some patient, the sperms are not permanently damaged, so naturally they can conceive. But if there is a sperm damage, then they can take help of the preserved sperms. That is in the case of a male patient. If it is a female patient, first we ask them to try to conceive naturally. And if they are not, Then we have IVF specialist, or we will ask, take the help of the gynec to see where is the problem.
Mm. All right. Okay. In terms of the stem cell procedure itself for BMT, what is the quantity of stem cells that is needed per patient?
Yeah, so that we have a formula or the dose. The stem cell we measure in terms of CD34 cells, and we generally give 3 to 5 million cells per kg of the recipient's weight. Like suppose if
Body
I'm,
weight.
yeah, so that's the standard. Like all over the world we do the same. If I'm 60, so I need uh, 60 or the 6 into 3, 1, like the standard 3 to 4 million cells per kg of the recipient.
Right, right. Okay, that's an interesting information. Yeah, thank you. And you said that sometimes after 4 or 5 years, a patient might require another dose of BMT to be done in certain cases.
Mm.
So if it is repeated in a lifetime, if you have, with the number of cases that you have seen, how many times a patient can undergo BMT? How many
Uh,
times can they repeat? Or has it been required? How many times has it been required to repeat?
it can be repeated, especially I told you about a condition called myeloma. If it is a younger patient and if the patient has relapsed and we have his or her cells preserved, then we can offer them a second transplant. That is an autologous. And allogenic, we have had instances where suppose the patients like high risk patient in a donor transplant, if they have relapsed, we have offered them a second transplant. But the number of transplants as we do, the chances of success become less. So maximum two times patients have undergone transplant, but the successes has not been so great because they have a very aggressive kind of disease.
Hmm. So it's vast spreading, or yeah, possibly. There's another question which we have already answered. If the female can have a baby, that's you've already answered. If anybody else has any question, or if you would like to come in and ask question to Dr. Ritu, please switch on your video so that we could give you an opportunity to ask question. It was a very informative, and in fact, it was you went down to the level of giving us basic information. It was eye-opening for even for myself. I didn't know many of the factors. That it was extremely interesting, and I think fundamentals we got to know today. Very useful information. Any other question? Otherwise, we come to the last segment of our session today. As there are no questions coming up, any last words from you, Dr. Ritu? There's one question coming up. Can cord blood stem cells also use as donor cells to other patients?
Yes, they can.
All right. Interesting. Means other patient in the sense, is it a non-children of that particular mother? Can you use it for others? Right.
Provided their facilities, you have a cord blood bank.
Right. All
So
right.
abroad in children, especially in the US and Israel, they have a lot of centers who are doing pediatric transplant and who have cord blood banks. So they can be used like donors.
Right. Fantastic. I think that is very useful in terms of helping a lot of people who would be really requiring, if they really have the habit of preserving cord blood as a regular process, that would really be useful for a lot of patients.
Yes.
Is there any chances of infection after BMT? I think you
Yes,
did
yes.
touch base on.
Infection is the first a nightmare for any transplanter. So that is
Correct.
the
That's the
one
reason
thing
you keep them in
I
isolation for
see.
2 to 3 weeks. So
Yes.
definitely. So after 3 weeks, do they need to be really focus more on hygiene and other stuff after going back home to be more?
For
Um,
a month, we advise them, not in isolation, but yes, general care. Because in the autologous, the immunity takes 3 to 4 months to build up. And after 6 months of the transplant, we revaccinate them, like how we vaccinate the children. We revaccinate them in autologous. And in allogenic, the immunity definitely takes sometimes 6 months, 1 year to get back. So precautions have to be taken, but not like, they have to be in isolation or they have to be in a complete different kind of a bubble kind of an environment. No, they go
No.
back to normal
Normal
life.
life, but a little bit of a precaution.
Precaution and follow. Yeah.
Follow up as well. All right. Yeah. Is there any new technologies being used in BMT transplant? As there is cyberknife, robotic, on other tumor based.
No.
Is there anything new?
Nothing is new. Only I always feel BMT is more of an art than science,
Right.
because there is no surgery involved, no skills, like we need a good surgeon or this thing. It's the team and the, experience of the entire team to pick up things before they are too late. So a
Correct.
vigilant team and that, that is, so we don't have much technologies. Yes, newer drugs are definitely there, newer way of managing the side effects, newer antibiotics, newer supportive care. So that, has led to more and more patients surviving this procedure. So the cyber knife robotic is, for the surgeons and
Surgeons,
other.
yeah,
Yes,
correct.
yes.
I think that makes the big mark in terms of when you say it's more of an art. And I think that's where we relate, connect to you, Dr. Ritu, as a person, because your connectivity with the people, the compassion that you show, and your not only compassion to people, the passion for your own craft that you do itself is shows the best art that you can produce in terms of the patient care. And I think that is where I can tell all of our colleagues we are 33 in number in this room today, that Dr. Ritu undoubtedly is the best hands that we could have in terms of bone marrow transplant procedure. Is there any chance to have the same blood disease to a new child? That means, is it a genetic disorder? If one child had a leukemia, does it mean that the other children would also get? Is it a genetic disorder?
Vidyaji, leukemia generally are not genetic disorders, but thalassemia, sickle cell anemia, these are generally genetic. But
Genetic.
leukemia, it's very rare. It's very rare that if suppose a sibling has, the second sibling also has. Very, very, very rare. But thalassemia, inborn error of metabolism, there are lot of genetic diseases of children where transplant is one of the curative treatment. But leukemia, no.
Right. I think we need to highly recommend people to come forward to take this treatment, not to lose hope in terms of their life. A lot of education and awareness is required in terms of making people understand the benefits of bone marrow transplant. I think with the two sessions that we had last time and today, I'm sure we've had wealth of information. And any of you in the audience, if you think that you wanted to ask a question but couldn't ask now, feel free to send us a message and we will be able to respond to you. So with this, we can come to the concluding part of the session today. I would like to immensely thank Dr. Ritu. I know for a senior consultant like you, it's not easy to come down to the level of non-clinicians to communicate the terminology and make us understand. It's very hard, but you have done an incredible job today to make us all understand the whole process. We have all, got such basic information that we were really eagerly waiting for. Thank you very much, Dr. Ritu. And not to forget our dear partner in this whole process, the person who has conceived the whole thought, the founder of Simplify MVT Academy. He's on the flight right now, flying high above, but he wants all of us also to fly high in our own careers. That's his motto. So thanking him for bringing this platform for all of us, and also to thank the entire team of Simplify MVT Academy for taking such passionate efforts to bring this session, to conceive all this session and reach out to everybody. Thank you, everybody. And the audience who have come, taken your time on a Saturday afternoon and make sure that you attend here, learn, and make this part of your success journey. So that's important. If you're not available, we could not do the session. So thank you to everybody who attended. And special thank you to Jahir Bhai from Bangladesh. It happens that all the time we have maximum number of attendees coming from Bangladesh. Kudos to you. And thanking everybody who are in the session, and see you all during next time. Goodbye. Goodbye, everybody.
I'm glad I could simplify. Thank you, Vidyaji. Have a great weekend. Thank you so much.
Thank you. Thank you, doctor. Bye, everyone.